Let's go ahead and finish up Mod 11 with ileus. Okay, and ileus just means that the intestines are not working. The peristalsis that is normally present in the intestine and in the colon are just simply not happening for whatever reason. Usually it's most common after an abdominal surgery, especially when you have manipulated the intestines while doing the surgery. So it's not really a form of obstruction when you're talking about that, but certainly ileus, it is different than obstruction, and that's the main thing that you really have to look out for to find out if it's just non-working, which is a temporary state, or whether it's going to be something that you have to deal with surgically. Alrighty, so let me see, what do we need to know about this? Well, usually there's some kind of inflammation, which is what's causing it in the first place, this ileus after a post-op. It could be something like appendicitis or diverticulitis, or even a perforated duodenal ulcer or something like that. Another reason would be like these retroperitoneal or intra-abdominal hematomas, like a ruptured abdominal aortic aneurysm or lumbar compression fracture is one of the things. You can also get them from an ileus from any kind of metabolic disturbance, like hypokalemia or taking opioids for that matter, or any kind of anticholinergic drugs or opioids, and sometimes even calcium channel blockers will do this. Alrighty, it's a little more rare, but sometimes even in a renal or kidney or thoracic disease like lower rib fractures or lower lobe pneumonias or even MIs will cause an ileus. But we're talking, again, it's just something that typically is transient, as in it's usually the colon that's infected that doesn't have the peristaltic waves happening, and 2 to 3 days is about when they tend to go away. Okay, the meconium ileus is a little bit different. That's more of a blockage kind of thing, where meconium, it's just that substance that fills the entire intestine before a baby is born. And it's made of, intestinal gland secretions and some amniotic fluid. And normally, it's supposed to be passed within the first 12 hours to 3 days after birth. Well, it's really, really sticky. When you're talking about a meconium ileus, it's abnormally sticky, and it sticks to the mucosa of the small intestine, and it won't let it pass beyond that terminal ileus, or ileum. And usually there's just a lack of digestive enzymes in the meconium ileus, and sometimes there's also albumin in there, which is, it's not normal to have that in meconium. So what you really have to look out for in meconium ileus, because it is dealing with, with infants and babies, is it could be a sign of cystic fibrosis because of that thick plugging mucus that you get with cystic fibrosis. So that's obviously one of the main things that you have to worry about is does this child in fact have cystic fibrosis, and you need to go ahead and do a sweat test, because in 90% of the time it's going to catch it if it in fact is the case that it's cystic fibrosis. Okay, now back to just general ileus again. The signs and symptoms, you're going to have it's some abdominal pain. It doesn't tend to be that much, is what they say. You got abdominal distension, and you're nauseous and vomiting. They say vague discomfort, right? Whatever that means. So what you're not going to really hear it when you stick the stethoscope on the abdomen. So you're not going to hear anything, or you're going to hear very little moving at all. Okay, and that's the main problem here. So to find out, you listen. So that's what it means by clinical with the stethoscope. And you can do x-rays to also see if there's some kind of blockage or something in there, just to be sure. Okay. The main thing, of course, is you have to make sure that it's not an intestinal obstruction, and you know, that's the main thing we're looking at. Is the other thing is, you know, it could be peritonitis or something like that. So you got to make sure that it's not up here. I guess I have it is peritonitis. Okay. The treatment, as far as that goes, well, the nasogastric tube, to go ahead and relieve the pressure in there, make sure that they get, you know, continuous nasogastric suction in there. Not supposed to eat anything, and you're definitely going to have to replace IV fluids and electrolytes to make sure, because there's, especially like potassium, you don't want to let your potassium drop very much. It has to be pretty normal, or that could obviously be a problem. You know, sedatives, got to go light on those things, and definitely avoid the opioids, the morphine, that sort of stuff, you know, because morphine or opioids of any kind and anticholinergic drugs will actually cause the peristalsis to stop a little bit and cause a lot of constipation. Okay. If this ileus persists more than a week, then there's probably some kind of mechanical structural cause, so you really have to be careful about that. This whole thing about chewing gum down here, actually, believe it or not, has been studied, and they do recommend that patients with a post-op ileus do chew gum, because that process of chewing gum will actually stimulate the intestines or colon to start working again. Okay, let's move on, if we can, to a little picture here, just showing again the meconium ileus over here. As you can see, all these little pockets of gas and meconium in there, I guess, and little things in here just filled in the, again, it's a small intestine when we're talking meconium ileus. Normally when we're talking about any kind of ileus, it's the large intestine that is not moving, but the meconium ileus is a little bit unusual because of that thick, like I said, that thick mucousy stuff. All right, again, here's our typical post-op ileus, where you can again see all of the big spaces in here with gas in the large intestine, which is usually where it is. I don't think I have anything else on there that's not already mentioned in here. Again, it usually resolves in 2 to 3 days. All right, irritable bowel syndrome. Moving on to one of our last topics here in this module, is irritable bowel syndrome. Just means that you have abdominal discomfort or pain. Okay, and you have to have one, abdominal pain, otherwise it's not irritable bowel, and it has to have one or two, at least two of these other things. Okay, so either it has to be relieved by defecation and a change in frequency of stool, or a change in consistency of stool. So it has to have two of these three things: relief, frequency, or consistency of stool, to be called irritable bowel syndrome. Alrighty. As far as the cause goes, well, they can't really find any anatomical cause for irritable bowel syndrome, at least for sure when you're looking at, you know, lab tests like X-rays and biopsies and that sort of things. There are some emotional or psychosocial things that they think maybe there's some kind of things going on there, like psychological distress seems to be pretty common in patients with irritable bowel syndrome. Anxiety disorders, depression, even somatization disorders, which are basically psychological issues that can cause or lead to a physical manifestation of it. However, that's not true in all patients. Okay. Again, usually have sleep disturbances with these patients, and sometimes, they call it a learned aberrant illness behavior. Sometimes where patients they express their emotional conflicts as a GI complaint. So that can always be one of the things. So, there's, probably in a lot of cases a psychosocial factor, but there's also just simply physiologic factors. Sometimes it's simply just these altered motility in the intestinal system, or what they call visceral hyperalgesia, and all that means is there's hypersensitivity to the normal amounts of the distension that you normally have when food hits your gut, and in a heightened sense of pain when the gut starts making intestinal gas. So they call that visceral hyperalgesia, which means, again, just hypersensitivity to pain really is what it's really talking about. Okay, there are some genetic and environmental factors involved in this too, but it's, again, irritable bowel syndrome is an interesting pathology because it's more of an exclusionary kind of thing where you're looking at everything else first. They do know that, sometimes like I said, there are some physical issues that they're simply not getting the contractions that you're supposed to have. It can be like a nervous malfunction in that enteric nervous system. Anyway, what really is it, the signs and symptoms? Well, you're talking about after you eat, it's uncomfortable is one thing. You have a exaggerated reflex from the stomach through the colon, and basically it can cause either constipation or diarrhea or anything in between that. Eating things like fat definitely will exacerbate the problem and make it even more worse. Make it even more worse. Okay. Anyway, also they've seen that there are some hormonal fluctuations in women that have to do with irritable bowel syndrome, especially during menses. Okay. There's some controversial stuff out there about small bowel bacteria overgrowth and irritable bowel syndrome, but no one has really proven that is the case. So we're still kind of out. The verdict's still out on that one. Probably wouldn't hurt either way to consider probiotics with someone with irritable bowel syndrome. As far as when it begins, usually people start noticing in the teens to the early 20s is when you start seeing cases of this, and it comes and goes throughout life, really. Like I said, it's triggered by food, especially fats, or even by stress. So there's definitely a link somewhere in there between the psychosocial and physiological parts of this. And it's worse or better depending on the person and really the situation and time that it's happening. It's really not that uncommon either to go back and forth between constipation and diarrhea. A word that we should probably throw in here at some point is dyspepsia. Dyspepsia is basically what we say when you have a abdominal sharp pain up in the stomach area. So, maybe I'll throw that word in here and there, but you should probably know what dyspepsia is, just pain in the upper gastric area. Alrighty. Along with irritable bowel syndrome, part of it is sometimes you get some of these what we call extra-intestinal symptoms, like fatigue and fibromyalgia, and I think I already said not being able to sleep very well, and chronic headaches. So it's a very, very difficult syndrome to really nail. When you're talking about trying to diagnose irritable bowel syndrome, most patients are way over-tested because you're looking for every single thing it could possibly be before you really settle on irritable bowel. There are some red flags, though, that we do have to worry about. If somebody, is older, or if they have a fever or massive amount of weight loss, rectal bleeding, or vomiting, that's really not part of irritable bowel. So that could suggest that it's completely something different and a lot more serious. Some of the things that we do actually get irritable bowel confused with a lot is somebody might have lactose intolerance or even a drug-induced diarrhea. The diarrhea that you get after removing your gallbladder is pretty similar to how that presents. Laxative abuse, of course, is something that definitely should be looked at. The patient may not realize that they're taking too many laxatives and causing it. Parasitic or diseases like giardia or something like that from drinking the fresh mountain spring water right out of the spring or something is, so any kind of parasites will do this too. Anyway, there's other things in there, but it's a little, again, more of an exclusionary kind of thing that we're talking about here. Let me see. If while looking at ileus, you really can't find anything, make sure that you also catch or check for hypothyroidism and hyperparathyroidism, because that can also mimic this a bit. Tropical sprue, celiac disease, Whipple disease, these are other things that definitely look a lot like irritable bowel syndrome. All right? So, a lot of times we will actually see in here a problem with familial interrelationships. Sometimes, like again, it is a psychosocial thing, so you have to pay special attention to that. So the overall emotional state of the patient has to be looked at pretty closely, including their quality of life and that sort of thing, to make sure that there is no underlying psychological issues that have to be dealt with. Okay? The physical exam, abdomen may be tender, especially in the lower left quadrant usually. Probably should definitely do a digital rectal exam and test for occult or bleed or blood out of the stool. In women, a pelvic exam, you kind of have to rule out ovarian tumors or cysts or endometriosis or something like that, because that can also sometimes present like irritable bowel does. Okay? One of the, I guess, best things is when you're talking about treating this, even though it could certainly go on for a lifetime in here, you need to really educate the patient and just tell them, it could be, it's not something that is bad as far as life-threatening or something like that. So that's the good part, is it can be, treated as far as that goes. And one of the best things, of course, in everything, it seems, is, regular physical activity actually does help relieve stress, but not only that, but it helps in the bowel function if it's one of the physiologic issues where you're not really getting that. A normal diet, they can eat pretty much anything they want, although definitely avoid fatty foods. And the meal should be fairly small, more frequent, more small, which is, well, it's true for everybody. Okay, might want to get rid of some of the things that cause gas and flatulence, like eliminating beans and cabbage, and those things that contain fermentable carbohydrates like that, and reduce the intake of sweeteners. Sorbitol, mannitol, fructose. These do tend to increase the bowel movements and the gas that would follow with it. Okay. As far as treatment with drugs go, there are some anticholinergic drugs like hyoscyamine that can be given half an hour to an hour before meals, and they will help with keeping the stomach from spazzing. There's also things like if you have diarrhea, there's things like loperamide or something like that you give before meals too. And one of the things, the tricyclic antidepressants, they actually relieve the symptoms of diarrhea, pain in the abdomen, and bloating. Plus, if there's a psychological thing in here, kind of catch that too. So the antidepressants, the tricyclic antidepressants, are pretty useful in this too. And like I said before, probiotics certainly couldn't hurt. They tend to be pretty good with, if nothing else, getting rid of the bloating part of it. What else? The last thing I guess I would say about this, there's some of these aromatic oils, they call them, and peppermint oil is probably the most used one that is supposed to be pretty good in treating irritable bowel disease. Okay, let's move on. Pancreatitis. Well, pancreatitis is, you kind of have to look at them almost separately because they're either acute or it's chronic pancreatitis. There's a lot of things they do have in common, like pancreatitis is one of those things, acute or chronic, where it can affect the exocrine system, as in the enzymes being released through ducts, or it can affect the endocrine system, which is when hormones are released directly into the blood. Okay, so let's look at acute pancreatitis first. Acute pancreatitis should be, it is supposed to be reversible. Okay, so out of the causes of acute pancreatitis, you have biliary tract disease, as in gallbladder, and alcohol. Together, they make up over 80% of the cases of acute pancreatitis. And what's really happening here is that whatever the cause is, it's the activated, what you're doing is you're activating pancreatic enzymes, but they're within the pancreas itself. Okay, and that's causing a whole cascade of things actually, but it's causing inflammation inside the pancreas, it's causing edema, and it's causing, in some cases, necrosis. And that's where obviously it gets very serious because, you can die from that. But anyway, so what's going on here is, like, for example, if it's an obstruction, like I said, with the biliary tract disease. If we're talking about biliary tract disease or the gallstone or gallbladder, it can be caused by obstruction. The pancreatitis can be caused by obstruction by a gallstone or even sludge from the gallbladder, and that can be what's responsible for releasing these activated pancreatic enzymes and eating away at the pancreas. As far as the alcohol part goes, we're talking about prolonged alcoholism that goes on for between 3 to 5 years probably. And what's really happening with that prolonged alcoholism that is going on for that long is these there's a protein in the pancreatic enzymes that actually start to precipitate or to build up, and you make these protein plugs, and the protein plugs obstruct the ducts so that you can't get the enzymes out of the pancreas, and therefore it starts eating away in the pancreas. Okay, there's a couple of do I want to get to that yet? About the there is, besides these two things, with the 80%, there's a couple of other things that will cause pancreatitis. But again, you're talking the other 20%, like there's a genetic mutation that can predispose somebody to pancreatitis. That's actually an autosomal dominant mutation. Cystic fibrosis is certainly one of those things that can cause pancreatitis. And either way, what we're talking about here is, again, back to that inflammation, edema, necrosis that goes on in there. And it's depending on how what we're talking about here makes a big difference on how serious this is. So if we look at here, if you're talking about just edema going on in the pancreas or in that area, then the prognosis is less than 5% die from this. But if you start seeing the necrosis and bleeding, hemorrhaging from the pancreas and pancreatitis, you're talking about 10 to 50% of people. And when it gets to the point where it gets overimposed by a bacterial infection coming from the gut, then unless that is very, very aggressively treated, then 100% of people are going to die from that. All right? And that usually happens about 5 to 7 days after you have an acute attack of pancreatitis. So that's obviously pretty serious stuff going on there. Can also lead to acute respiratory distress syndrome and renal failure once you start seeing the activated enzymes get into the system and attack from there and start causing a cascade of reactions. Alrighty. As far as how it looks like, pain is either sudden or over a few days. Okay, sudden is usually the gallbladder, and over a few days is usually the alcohol. This person looks, what we say, acutely ill. Okay, they come in and they are just clearly sick. Their pulse is really, really fast and having really low respirations as in breathing. Blood pressure and temperature kind of goes either way. Sometimes it's really high and then it will drop really low. Same with temperature. The same thing. Sometimes they're so out of it that they come in pretty much in a semi-coma. Another thing that you'll see with pancreatitis acute is that scleroicterus, or the yellowing of the eyes. And it can lead to actually collapsing your lungs, the atelectasis. And we already talked about ascites from the edema, I think. All right, so again, very, very serious issue here. What else? How you diagnosing this thing? Well, you're going to find increased amylase and lipase in the blood. You're going to see a white blood cell count that is not incredibly high, but it's definitely going to be around 11 or 12,000 at least, and 10,000s, 5 to 10,000 is normal. Your hematocrit will be messed up as far as the level of hematocrit goes. Let me see. Hang on one second. Let me think about this. Yeah. The hematocrit, it can go as high as 50 to 55% because of fluid losses when you're talking about third spacing from that edema. And so it looks like your hematocrit goes really, really high because you're losing so much fluid that's basically going into your tissues instead of staying in your blood. All right. As far as the blood sugar goes, you see hyperglycemia, and bilirubin shoots up also. Calcium is actually decreased, and the weird part about that calcium decreased is because you're making actually calcium soaps, because of the free fatty acids that are being generated by this pancreatic lipase that's running around and eating everything up and making all these acids, and it's using the calcium to make soap out of that. Okay, so that's obviously not a good thing. Okay, as far as looking at it with trying to visualize it, abdominal X-ray probably can catch it, and ultrasound. If you already expect that it's gallstone pancreatitis, you should definitely do an ultrasound to make sure that it is in fact that. Okay. As far as treatment goes, you really have to give them lots of fluids. Make sure that they're fasting so that those enzymes aren't being stimulated anymore. Drugs, as far as pain medicine, and we're talking serious pain medicine here. In fact, that's one of the major problems with pancreatitis is it hurts so bad that you have to pretty much give them morphine or some pretty serious drugs like that, and then you get addicted to the opioids. Okay, obviously if there's an antibiotic, you'll need antibiotics if it's a severe infection or something like that, and if you get some kind of, again, infection, then you definitely have to go in there and surgically drain it, again, really fast, or 100% of them will die from that. Okay, let's kind of move on here to the chronic pancreatitis. It's chronic pancreatitis, like the acute, has a lot to do with alcohol, but now you're talking 70-80% just from alcohol for the chronic pancreatitis. And then there's the other that we just really don't know, really, the rest of that, idiopathic. Obviously, if you had acute pancreatitis attacks in the past, then we obviously know why you have chronic pancreatitis now. Okay. So, what else? Signs and symptoms, again, recurrent attacks, because maybe you had acute pancreatitis before, and so now it just keeps coming back and coming back. That's why it's chronic. You're certainly going to have the malabsorption problems because of your enzymes all messed up, and because of that, we already talked about in acute the increased glucose in the blood. So now we're talking about diabetes too. A lot of 20-30% end up actually going on to develop diabetes. All right, so again, like I said, the history is important. If there was acute pancreatitis, X-ray, look at that thing, abdominal CT, to make sure that if there's some kind of ductal obstruction, either by the proteins from the alcoholism or from the biliary tract disease, and you've got gallstones or something looking in there. So you're going to want to definitely look at it somehow. That MRCP is kind of the new thing, the magnetic resonance cholangiopancreatography, I believe is how you say that. Cholangiopancreatography, kind of like a mix of cholecystitis or gallbladder thing, inflammation, and pancreatitis. So anyway, this MRCP is the new thing where you're looking, and you can see that a lot better than even CTs. So the MRCP is probably the newest thing to actually look at it, although you can definitely see the calcification on a plain old X-ray if that's the case. Alrighty. Oh, as far as chronic pancreatitis goes, after you continue to have episodes and episodes and episodes, after you get like to 6 to 10 years, then you really don't have the episodes of these pancreatic attacks anymore, because it actually, the digestive enzymes finally just go ahead and eat everything through, and you don't have them anymore. So it runs itself out of digestive enzymes, and your symptoms kind of subside after after 6 to 10 years of this, that doesn't mean that you're off the hook, but the symptoms kind of do decide or subside after the enzymes basically eat away their ability to secrete anymore. Okay, as far as treatment goes, pretty much the same thing. All right, the fluids, the fasting, the diet low in fat, the heavy drugs, unfortunately, and enzymes by pill form for the rest of your life, as far as that goes. Alrighty, yeah, you can. As far as some of these drugs go, you're talking, yes, the pain drugs, but you're also talking about H2 blockers and proton pump inhibitors, so you can reduce the acid in the stomach. If you reduce the acid in the stomach, you'll reduce the pancreatic secretions also that are responding to the acid in the stomach. Alrighty. I think that's about it on pancreatitis, except obviously, you'd have to add insulin if it as another drug, if in fact it did go to destroying the pancreas to the point where it's not making insulin anymore. And problem with insulin is you also have to be very careful, because the pancreas also makes glucagon, and insulin puts blood sugar out of the blood into storage, and glucagon takes it back out. So they're both made in the pancreas. So that is a potential problem if you give insulin and now glucagon has nothing, or there's no glucagon, so there's no way to get it back out. So it's an issue in that too. Anyway, I think that concludes this module finally. Thanks for being patient, and we'll see you around.